In this video, we demonstrate treatment of an indirect CC fistula through a transvenous route utilizing the common facial vein and illustrate some of the pitfalls and tricks important in achieving an effective result. Different transvenous approaches can be used to reach the cavernous sinus, utilizing one of the several veins originating from this area. The transvenous route through the facial vein is not commonly utilized because of its tortuosity and the long reach. However, this approach represents a valid alternative, especially when the exclusive drainage of the fistula is through the ophthalmic veins. This 55-year-old female presented with the pulsatile bruit 4 months before evaluation. The bruit spontaneously resolved, but 1 month before treatment, she started experiencing left eye proptosis, hyperemia, and intermittent double vision. The symptoms were worse in the morning and would improve with upright position throughout the day. Catheter angiography shows an indirect CC fistula. The fistula consists of a dural arterial network from cavernous branches of the left ICA and through collaterals from the contralateral internal carotid artery. The arterial network drains into a venous pouch and eventually into the ophthalmic vein. The venous pouch could represent the thrombosed end of the upper portion of the inferior petrosal sinus. Probably at some point the fistula was draining primarily through the inferior petrosal sinus, hence the clinical symptom of a pulsatile bruit. As the IPS thrombosed, the drainage shifted exclusively to the ophthalmic vein, causing visual symptoms. We tried first an approach through the inferior petrosal sinus, but we were unable to reach the point of fistula. We then opted for a transvenous approach through the facial vein. In the late venous phase, on the left common carotid angiogram, the full course of the superficial facial vein from its origin is identified, and the road map of the late venous phase is obtained. A vertebral catheter is advanced to engage the origin of the facial vein. In order to provide adequate support so that the microcatheter can make the initial sharp curve of the vein, it is important that the origin of the vein is engaged with the tip of the supporting catheter. The microguide wire is used to gently probe the origin of the common facial vein. Once the distal facial vein is catheterized, under high magnification, a new road map is obtained to facilitate catheterization of the most distal portion of the vein. Making the sharp curve around to navigate past the superior root of the superior ophthalmic vein is the most challenging part of the procedure. Navigation of this segment is possible only after the tip of the microguide wire forms a loop. At the same time, in order to gain additional proximal support in this part of the procedure, the supporting vertebral catheter is advanced over the microcatheter well into the facial vein. The road map is updated, and with this additional proximal support in the loop of the microguide wire, the tortuous curve can now be navigated, providing access to the dilated ophthalmic vein and the anterior cavernous sinus. Selective microcatheter injection confirms proper position of the microcatheter into the most proximal venous drainage. Detachable coils are deployed to selectively obliterate this portion of the cavernous sinus. Final angiographic runs from the left and right carotid confirm complete obliteration of the venous drainage. The patient was discharged on postoperative day 1 and experienced a resolution of her symptoms. A time-resolved MRA and MRV is planned at 6 months to confirm persistent obliteration of the fistula.